We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together.
This is the best effing job in the world. And it's something that's so beautiful about orthopedics, though, because taking care of teenagers, you're taking care of today, did shoulder replacements on 80-year-olds. And so everyone's at just such a cool phase of life that you can enjoy each phase of life that they're at. And it's always great to be, as a physician or surgeon, to be a healthcare consumer, because you forget really what
it's like to be on the other side.
And it's good to be on the other side. You need to understand what it's like for, to be on the other side. But you realize, like, wow, man, like I'm really asking a lot of this person, and putting the trust in them, and you take that for granted sometimes, I think, because it's what you do all day, every day. But it really is. It's a privilege and an honor, and I think you always have to remind yourself of that.
Absolutely. We are so excited to have our guest here, Dr. Paul Fenton. He is an absolute expert in the shoulder and the knee. He is a board-certified, fellowship-trained orthopedic surgeon in our community, and he is really good at connecting the community. I love what he does. Welcome to the podcast, Dr. Fenton.
Thanks, Brad. It's just a pleasure to be here. It really is. You and I have been working together for a long time, and I'm truly honored and excited to be here. This is just a great idea.
Well, thank you. Thanks for coming and sharing your expertise, because a lot of our followers want to hear from surgeons, what goes on in their brains, how do they make decisions, how do they guide people on care, what's most important, because we lean on different areas of healthcare at different times, and a lot of people have a deep trust in surgeons and their expertise and their opinions.
I think they do, and it's truly an honor. I don't think people really realize that as much of how grateful we are to patients. I always tell patients, I get way more from you than you'll ever get from me. You enjoy them, but I mean, it's truly an honor, and I tell them it's an honor and a privilege to take care of you. There's a lot of people you can go to, and we're blessed in Salt Lake. There's a lot of great healthcare providers, and I think this town has a great quality of care, but it's a big deal. I even know personally, and my wife's had surgery, and when you see it from the flip side, you kind of, and it's always great to be, as a physician or surgeon, to be a healthcare consumer, because you forget really what
it's like to be on the other side.
Exactly, and it's good to be on the other side. You need to understand what it's like for to be on the other side. But you realize, like, wow, man, like I'm really asking a lot of this person, and I'm putting the trust in them, and you take that for granted sometimes, I think, because it's what you do all day, every day. But it really is. It's a privilege and an honor, and I think you always have to remind yourself of that. And
absolutely. Also,
how important this really is to this person. That this surgery, no matter what, big or small, it's the biggest.
There's a weight that comes with that, for sure.
It is, and it's probably the biggest thing going on in their life, right? And it's the most important thing to them. And you think, well, I'm doing 5 surgeries today, and this is all, and it's all basic, and you go, it's not basic to them. And
it's a big part of their life. This could change their life forever in this moment.
Yeah.
And so often we just get in our routines, right?
Exactly.
2 years ago, I broke both my hands. I don't know if you know this, but I was in a motorcycle accident. I broke my wrist on my right, my hand on my left. And as you know, as a therapist, that's what I do all day.
It's your lifeblood.
Right. And I broke my scaphoid, and you know the anatomy of scaphoid. If it breaks in half, you got to pin it together.
Yeah.
It only gets blood flow from one side.
It's trouble.
And I had to get surgery. It turned my life upside down. Literally my whole day is using my hands. And I was in a very dark place, and it was just like you're saying, it was a good reminder to be on the other side, to remember to be compassionate, and to remember to treat every patient like they're human.
of how important this really is.
Because we get too much in the routine, you know, and we're just like cranking things. We're going.
Yeah.
But we got to remember these are human beings that we're treating. I love that about you. Every patient that works with you, and then I work with them, they are a raving fan of you.
Well, thanks. That's
your
nice
bedside manner is next level. Tell me, I mean, you've been doing this for 25 years. First of all, let's give us a little bit of background on, you know, what you've done through the 25 years.
Well, I'm an Ohio boy originally, and so I went to undergrad and in med school in Ohio, and then I had the privilege of coming out here after my orthopedic residency and training at Tosh, and so I had some really great mentors, and Dr. Paulus and Rosenberg and Beck, and they kind of really helped take it to the next level as far as my skill set and the knee and shoulder stuff. And then I was really, really, really fortunate. I was asked to come back to Ohio where I trained with two of the guys that I had trained with, and they were kind of my two mentors and two people that were really instrumental in my life. And the senior partner, Dr. Sadami, who had trained me, was just, you know, he was the guy that I looked up to, and you know, and I saw how he treated people, and you can. When you're training and you're a young surgeon, you know, you can learn all you want about, you know, the technical side, and we spend so much time learning in the technical side of things because that's so important. And you just don't realize, like, there's another side that's even more important, and you gotta grasp it. And you know, he taught me that. He taught me how to, you know, just the things. He just reminded you of, like, even your demeanor in the OR and how you treat your nurses and your staff and those people, you know, and just it means everything. And he was just so I really, even young, when I came into my training as a young surgeon, I had really good mentors and people that I looked up to. And so I was, you know, just super blessed with that. Tell us
of the caliber of patients you've had over the years. 25 years, you got to have some really high level athletes. And
we did. We took care of a lot. We took care of the university, and so you know, that's always fun. And I think
collegiate type athletes,
collegiate athletics, and that's always really fun. And I think that, you know, the collegiate high school stuff, I think, is by far the most fun, and obviously just your recreational type of athletes. And you realize, especially as I've aged and everything, you know, that hockey game or rec league soccer game is as important to the 45-year-old as the high school game is to the 17-year-old. And you're holding on to your youth, and you're holding on to everything, and you know, and you guys, and so, you know, again, that's important. But yes, we've taken care of, you know, professional, more collegiate level athletes, high school level athletes. We took care of I was in Toledo, so we took care of the hockey teams and the professional baseball teams, things like that. But, you know, that's a different animal altogether, particularly baseball. But
yeah, exactly. I mean, today we're talking about, you know, the team-based approach to shoulder care. And as you know, the shoulder is one of the most complicated joints in the body. Give us some anatomy and some things that come to mind as we're talking about the complexity of the shoulder.
You're right, and that's kind of what's always fascinated me about it. And I did my training in both knee and shoulder, but my practice just tend to evolve to more shoulder work, just because I was like, wow, like, it's one of those things, the more you know, the less you know. You know, and you keep studying, you keep going to courses, and you keep reading the literature.
And you're like, it's one joint, how hard can it be?
Like, how can people spend their life doing one joint? You're like, God, yeah, you can. And so, you know, it's a super complex joint. It's the most mobile joint in the body, and I think that's kind of what...
And mobile as in, like, has the most amount of range of motion, right?
Exactly.
We talk about degrees of freedom in physical therapy. Yeah. You literally create more motion out of the shoulder than any joint in the entire body.
Yeah, I mean, if you think of your knee or your elbow, it kind of moves in one plane and a little bit in some other planes, but it's not supposed to. And the shoulder is supposed to move in all these different planes, and as it connects your basically your torso to your extremities in your extremity. And so it's just incredibly, it's fascinating. It really is, you know, and really where we've come with the evolution of stuff that's happened in the shoulder, and both with arthroplasty and instability and the things, you know, and it's the things you thought you knew even 10, 15 years ago, you know, are they were the basis for what we have now, but they're antiquated. And you realize, in 2035, we're going to be talking about different
approaches,
different surgeries, different approaches, different things like that. So
one thing I want to add on the shoulder, and we talk about how much motion it has.
Yeah,
I mean, really, the reason it has the much motion as it does is because the socket is 1/3 the size of the ball.
Exactly.
And
exactly.
It's similar to a golf ball on a tee.
Exactly. That's the
ratio, right?
Yeah.
And because of that, you think about how easy it is to push a golf ball off a tee. It becomes very unstable, right? So talk to me about the structures around the shoulder that create stability.
So it's an inherently unstable joint, okay? And so there's really...
Which allows for motion, right?
Exactly. So, and so you've got your bony anatomy, but your bony anatomy is a little bit deficient because, again, like you said, that
it's not
socket,
surface area.
What we call the glenoid, is 1/3 the surface area of the ball, which is the humerus or the upper part of the arm bone. And so then there's what they call the labrum, which is almost like an O-ring that attaches around the socket, around the glenoid, and that is kind of an attachment point for the ligaments, which ligaments attach bone to bone. So there's ligaments there's structures that attach the humerus or the arm bone to the socket, and so those ligaments...
So it kind of creates a little bit more stability with the ligaments.
Yeah, so
and ligaments are what attach bone to bone or soft tissue to soft tissue, right?
Yeah, and tendons will attach muscle to bone. So you've got this layer, what we call the capsule, which is a kind of a thin layer of tissue that's kind of the deepest layer around the shoulder joint. And then on top of the capsule, then you have the muscle. So you have the rotator cuff muscles, and you have different structures that are soft tissue. And so there's both the complexity of the muscles moving and all those different ranges of motion that the muscles have to coordinate to get, but then also it has to provide some stability.
So in essence, this is like a symphony.
Working
together. Everyone has a role, and if you ain't doing your role, it's messing everything up,
exactly.
Right?
And then so that's the general level of stability. But then when we start looking at other stabilizing structures, which is where you guys come in much more than we do. You've got when we look at throwers and you look at core strength and pelvic stability and all these things, then you realize, how complex it is, like to throw a baseball.
Yeah.
And you realize, one pitch in a baseball, if you looked at the whole symphony of what happened, it's unbelievable.
The real question of this podcast is how many patients say rotator cuff, and that's CUP.
Probably about, let's go about 30%.
Okay,
like
30%.
Yeah.
It always makes you giggle a little bit, right?
A rotary cup. There's a rotary cup. We do cups, we do cuffs. There's a lot of rotary
all
stuff
the different
too.
rotary things, something, right? But ultimately, it's rotator cuff.
Yes. Exactly.
How many rotator cuff muscles do we have?
So there's 4 muscles, and all those muscles attach basically on the shoulder blade or the scapula. And then there's one main muscle in the front, what we call the subscapularis, and then there's one muscle on the top, and what we call the supraspinatus, and then there's 2 in the back, what we call the teres minor and the infraspinatus. And so the problem is they're 4 very separate entities, but we all tend to group them, and we say we have a rotator cuff tear or something like that. But that can, when we say those type of things, that is a broad spectrum of injuries, and there's a lot of things that entail a rotator cuff tear. But there is some damage,
and we're gonna dive super deep into these rotator cuff tears, and that's going to be the main topic we discuss today. But just keep in mind as we're discussing this, I mean, Dr. Fenton just talked about the labrum. He talked about ligaments. He talked about tendons, right? All the capsule. There are multiple things that can be going on with your shoulder. Today, we're just diving deep into rotator cuff tears, right? And what those rotator cuff tears mean. What is the most frequent rotator cuff tear that you see in clinic?
It's probably what we call the supraspinatus tear, okay? And that is the muscle that's on top of the shoulder, okay? The muscle in the front was what we call the subscapularis, but usually, and then when we talk about tears, there's such a broad spectrum. There's partial tears, there's complete tears, and then once we even get into complete tears, we kind of subclassify those as small, medium, large, and massive. And so
And is massive complete, like full rupture?
Well, massive would be a size. So massive is usually considered greater than 5 centimeters or 2 tendons. So
Okay.
in a lot of times, and if you look at the anatomy, where the supraspinatus attaches is very confluent with where the infraspinatus attaches. We used to think the supraspinatus had this big, long, wide attachment at the end of the arm bone, but it's actually a little smaller, and the infraspinatus tends to come and wrap around that. So they tend to kind of, a lot of times they can tear together.
Yeah.
Okay. And so, but it's kind of like, it's a very thick attachment of about 14 millimeters of the whole, that's about the thickness of the cuff attachment. But so what happens is a lot of times these start as partial tears, and think of it just kind of like a rope, you know, and you've got some of these fibers that begin to unwind. And so over the course of time, whether these are traumatic, degenerative, all kinds of different things, those fibers begin to kind of unwind. And then you've got now maybe 20% of those fibers are torn and 80% are doing the work. Well, eventually they begin to fail, and just like kind of a rope or a cable that's beginning to unwind, and then eventually the whole thing can fail. Or again, you can have you can have a fall. And a lot of times what we'll see too is just, you may have cuff disease that you don't even know about.
Yeah, it just happens over time.
It is, and you're not...
Some fraying, maybe some abuse, maybe
Yeah.
you've done repetitive motion the exact same way. Maybe you've developed bone spurs that are kind of, tearing at that tendon over time.
Exactly. And
Why is the supraspinatus the most damaged? What happens there?
What probably takes the most stress, because there's a lot of, particularly with overhead type work, and that really is probably the main reason why that goes. And so there's different vascularities. There's also areas of differential vascularity to that tendon. So there's some small areas of that tendon that don't have as good a vascularity. So perhaps there's a minor injury that with another muscle, like say the subscap, which has a better vascularity, that might heal on its own. So you've got this area that's not getting as much blood supply. Again, then you throw in other factors like smokers or like people with diabetes, health issues. So they just, that tendon doesn't seem to heal as well. And so it's not. And I mean, honestly, if you took 150-year-olds who've never had a shoulder pain in their life, said, I've never had any issue with shoulder pain, threw them in an MRI, 50% of them would have cuff disease.
Yeah, and
so,
we've talked a lot about imaging even today. With another podcast, is the importance of correlating their pain with what's actually on the MRI.
Exactly.
Right? So many people will see the MRI, and research shows that if they see their MRI and they already had pain, their pain score goes up 3 points the minute they see the MRI. Why is that?
Well, I think it's just because of validation,
That's the reason I'm hurting. There's 17 things wrong with my shoulder.
And we run into that all the time. I had a really, really nice lady in the office yesterday who came in, and she had an MRI that showed she had a partial cuff tear.
Yeah.
But her main problem was numbness and tingling in her arm, and we kept talking, and every question I had, she had nothing to do with her shoulder. She said, "Oh, my shoulder's fine. I've been digging in the garden, blah, blah, blah. I've got, but my arm goes numb all the time. It's numb when I'm sleeping." And consequently, I said, let's get some x-rays of your neck. And she had terrible neck arthritis and things. But, we talked about that. And I said, this is about treating an MRI. You've got something on your MRI, but you've never had shoulder problems in your life, and we're going to obviously address your neck long before.
Yeah, all of a sudden the shoulder hurts, and we're like, well, you do have a small rotator cuff tear here, and then you operate on it, fix the rotator cuff, but it doesn't solve their problem.
No, exactly.
How damaging is that?
Exactly, and that really goes to your whole team approach type of thing of, and it's a problem a little bit of the over imaging, because as soon as you get an MRI, we all think, and particularly patients, that's gospel, whatever. Or
it's the golden treatment, or the golden answer.
Yeah, or they're like, my shoulder hurt. People come into the office, say, my shoulder hurts, I need an MRI. I go, let's delve into this a little bit further and do.
And the clinical practice guidelines actually steer away from imaging early on now.
Yeah, and
usually it's like, let's go through conservative treatment first, therapy, because it can be very damaging to you to know all the things that are quote unquote wrong with your shoulder when they're really not wrong.
No, exactly.
Just part of aging.
Exactly. And a lot of those are even subjective. And then it's how it's read. You know, the MRIs are nothing but gray and different shades of white, gray, and black. And radiologists do a great job of reading these and everything, but they're still subjective. There's things I read that I'll differ with a radiologist, and that's not, nobody's right.
You're like, I don't agree with that, yeah.
Well, and they would look at me, and sometimes it's, I don't agree with that either. So these are, nobody's right and nobody's wrong, but there's an area of subjectivity in these things, and so you can't latch on to
and
that.
patients will see their MRI and they'll read the interpretations, and it can be very damaging to them for the rest of their life when they read that. And I even, you know, I love transparency with medical notes, but I have a strong feeling that patients should be blind to their MRI. We should not be giving them that interpretation, because they don't have the ability to actually to digest that information appropriately.
Sure, but if you see MRI partial tear, you know, a partial articular surface tear, which means a tear of the fibers that are connecting to the joint side rather than to the top side of the cuff, you know, people are like, I have a rotator cuff tear, and it could be 10% of the fibers, and you can go, this is a very normal finding. This isn't, and you know, and does it correlate with what you're telling me and what's your history and what's on your physical exam? You know, and those are the things that you have to go and lean on and ask the right questions. Absolutely. And you know, and kind of have that rapport with, and important for the patients to kind of tell us everything, you know, because sometimes people do come in and they just are like, hey man, I got this MRI and this is what I have, you know, fix it. And they've, you know, and
they've done their own research. And
I mean, you know, Google, the internet is the bane of our existence. Exactly. And it's a double-edged sword. You want people to be educated. You want them to know as much as possible. And people ask great questions, and they have a lot of, you know, they're very on track. But, you know, there's the internet's an unfiltered massive information.
Yeah.
So,
we had a whole podcast
difficult
on AI and how AI is sometimes very outdated. Like the information, the algorithms it pulls from is 20 years ago. And you were just talking about the advancements of what could happen in 10 years. Like the treatments that we could offer, shoulder replacement or shoulder replacements or rotator cuff tears, surgical approaches, they could be extremely different in 10 years. And you're pulling this AI data that's 20 years ago that is completely inaccurate based on what we're doing today.
It is. It is. And so, and again, this goes along with exactly what you're saying, you know, and we need to all, you know, it's why I love working with you and with these different patients, is because it's like the most important thing is they're getting a consistent message from everybody, you know, and that is where that's where the communication breaks down, I think. When the communication breaks down, and that's what leads to a lot of
mistrust, frustration.
A lot of frustration. Brad said this, Paul said this, he said, and it's like, you know, and that's
I love that about you, Paul. We kind of have this unwritten rule we've never really talked about, but Paul will call me anytime and I'm going to answer. And same on your side, right? We've never really talked about it.
Yeah, I've called you dinner time a couple times. I'm like, I don't mean to interrupt family time, but I just got to.
But it's always short, sweet. We know what we need to get to, and
it's like I just
good to chat, man.
I just got to tell you about this patient. I just got to tell you what's going on. They're coming to see you, and you know.
Yeah, because there has been times where maybe we're slightly off on our communication, and you talk to the patient, and you're like, all right, we gotta actually touch base verbally on this.
Yeah,
which is so helpful, and that's what the revolution's all about. Is the only person in the driver's seat is the patient.
Yeah.
You know, we're in the back seat helping them navigate, but ultimately we're a team. And if we're not all talking the same language, and I'm saying right and you're saying left, it can be very damaging for the patient.
It is. It's extremely frustrating, and it's just something it's frustrating on everybody's part. You know, I mean, I know, you know, you'll get something be like, well, Dr. Fenton said this, and blah blah blah, and you're like, what the heck? You know, that should.
I actually have a story that I want to share.
And so. You know, and the worst is the patient's caught in the middle, and that is, you know, the healthcare and the consumption of healthcare is hard enough as it is. You know, it's complex, and like you said, people are in their silos, and you know, and you're just trying to do what's best for you as a patient, as a consumer, and if you know, and you know, I don't think I personally think there's nothing more important than kind of the surgeon therapist
relationship,
because that's the true partnership of, you know, I tell patients all the time, listen, you know, I mean, good surgery and bad therapy, you're not going to get a good result.
Yeah.
And if you do bad surgery and good therapy, you're not going to get a good result either. But you got to get good and and I mean, I send you a lot of complex patients. There's people I'm like, Brad, this is going to be a tough one.
Yeah.
But it's just that it's great for me knowing, hey, listen, I can get on the phone
and I have to know what
Yeah.
the quality of the tissue was that you operated on, right?
Yeah.
If I don't know, say I'm working on a shoulder and the quality of the tissue was very poor, right?
Absolutely.
Yeah. And how would you describe someone's tissue that is very poor quality?
Almost like wet tissue paper sometimes.
Like
And
you
so
go to sew it together and it just kind of
Yeah.
falls apart,
Yeah,
right?
exactly. And that's the whole thing, with rotator cuff repairs. I mean, we talk about like there are thousands of different types, different types of tears. Everybody's different of how many tendons were torn, how badly these tendons were torn, how badly they're retracted. Did we have to do releases to get this back? And then
retracted means like when it's actually torn, it's pulled apart and there's a gap between the tissue and you have to pull it back together.
Yeah, so
how long that's been apart is crucial too, right? It's been
Exactly.
20 years pulled apart.
Yeah,
The quality of tissue is going to be really poor.
Yeah, and if that tissue hasn't undergone normal physiologic stresses, which by raising your arm, by having those neuromuscular coordinations, then the tissue will degenerate. And we see that also with the muscle. Like if we look on the MRI, if there's fat that has infiltrated the muscle, we know that's been torn for quite some time. And people will be offended. I'm like, if I have to show them there's fat in your muscle, I'm saying this is not. You're
not
fat.
saying you're fat.
No, this is just saying.
Tell us why that happens. Why does the body send fatty infiltration into a muscle when it's damaged or tissue?
Because it's just like when you look at a cow and you say, wow, that's great, that's all fat and marbled, and you go, that's great steak. Well, that's not great muscle for us. And so when it doesn't get the normal neuromuscular stimulation and it just sits sedentary and that muscle isn't contracting, and so if the tendon is torn away from the bone, it's not able to perform its normal function. So therefore, the muscle is not really performing its normal function.
Yeah.
And
then when you sew it back together, how does that influence rehab?
Okay. Well, it's a great question because there's different some people you look and you go, oh, this was a very recent tear. They have really good quality tissue. They had good quality bone, and typically when we sew it together, when we repair the tendon to the bone, we use what we call anchors. So they're kind of like screws, or there's many different types of anchors, but the basis of it is that it's an implantable device that goes into the bone, that's fixed into the bone.
Yeah.
And then these have sutures, and then we pass the sutures up through the tendon and tie them or connect them in multiple different ways. So basically, the tendon is reattached to the bone by tying the sutures on top of the tendon to reattach.
And if the quality of tissue is really poor, as a physical therapist, I need to know that, because if I just get your protocol or I just get your note that says rotator cuff tear, and it's this really poor quality, and I put them on a moderate intensive protocol.
Exactly.
Like, I need to be very conservative with that patient. I'm going to hold off on doing even passive range of motion for some time. Maybe we're not even going to start for 6 to 8 weeks, because I want that to solidify before we get going.
But that's my job. My job is to communicate that to you. You don't know that, if I haven't, then, there's nothing I love more than a phone call from you that says, hey man, what was the quality of his tissue? I'm thinking Brad's on top of stuff and I've dropped the ball and I need to communicate. Typically we try to write that in our prescription. So, hey, 2 centimeter
And you do
tear,
a good job. Your penmanship could use some work, but
so maybe that's Bob's.
Because it's Bob.
No,
we'll give Bob a hard time.
No, it's all me. But anyway, it's but the super.
I can still read it though.
And how big the tear is, and all those things. Those are the parameters that you guys need to know, because there's a different protocol for each one.
Yeah, I had this one patient that we were sharing a while back. If you remember this patient, he had a total knee replacement that I think you did, and then he had fallen like the next day and tore his rotator cuff.
Yeah.
And it was early on in his knee, and he went to you. This is good communication that we had. I loved it. He went to you, and he came back, and he says, he called, And he says, Dr. Fenton says that I should stop doing everything and just rest and sit on the couch. And I've worked with you long enough. I'm like, well, that doesn't sound like Paul. Let me give Paul a quick ring and let's make sure we're on the same page.
Yeah.
And I remember I just sent you a text and I said, this patient, are you okay with them starting therapy with their knee only so we can get their knee going? They just had surgery. And we hold off on the shoulder. I'll make sure we're not pushing through that shoulder at all.
Yeah.
And you're like, absolutely, get them going.
Oh, yeah.
Right?
I mean,
the patient's perception was Paul, or Dr. Fenton told me don't move at all. Right?
Yeah.
And that wasn't what you said, right?
No.
But he interpreted it that way. And that's another reason why we all work together, because the perception of the patient can sometimes be different than what the actual provider said.
Absolutely. And it is. And if we rely on the patient to be the messenger, it's a fairly unreliable messenger. Not a criticism to the patient at all, but anytime it's the telephone game, and people just hear different things, and so that's
and there's
why,
so much information that they're having to filter out.
They're
They're like, oh my gosh, I'm not even going to be able to work for 6 weeks, 8 weeks. Like, the last thing they're remembering is what instruction you gave them.
Exactly, and that's what I mean. And if we rely on that, and there's thing, when people come in and they'd say, hey, this is what Brad said, you'd be like, that doesn't line up.
Yeah,
exactly.
And I think that's something really important for our healthcare community to remember, and also patients. We have to remember each other by our ceilings and not make assumptions. Especially in healthcare world, we're like, oh, freaking Dr. Fenton, just like, oh, that dog, telling them not to keep doing therapy.
Yeah.
But ultimately, that's why we have to know each other. That's why we have to develop trust in each other, is because when things don't line up, I could have easily said like, okay, well, let's just wait. Yeah. But what would that have done to his knee?
Yeah.
Just
he
resting.
Comes back with a stiff
right?
knee, and then I would have been like,
and then the surgical outcome's crappy.
I
like
told you not to do that. Exactly.
And then it just starts this negative outcome for the patient, right? I really want to emphasize, like, that's the importance of this relationship. Yeah. We have to work together in coordination and for the best outcomes of the patient.
But it's also one of the most gratifying parts of my job is doing that. And I think, we're to be criticized too. And I mean, that there's a lot of people like, oh, well, I was afraid to call your office. I didn't want to bother you.
I know you're busy.
No, and there's nothing where, I mean, if as a surgeon, you're giving off that aura of like, I'm too busy to talk to you. I'm too busy to talk to a therapist or something like that. We're busy. You're busy. Everyone's busy. Our patients are busy. That's a, you and I have had 20-second phone conversations
for sure,
and but you get a lot out of that 20 seconds but I'm saying that's up to the surgeon too, and it's up to to say, listen, I'm an open door. You should feel free to call me anytime.
What advice do you have to providers in that world on creating channels of communication with patients? I think it's a really hard area for patients.
Well, I'm talking more therapist. I'm talking like you calling me, like some, it's hard with patients because, they need to know that they have access and you're going to answer their questions and things like that. But, and you can't say, hey, listen, I mean, I say, listen, call anytime and we'll try to get back with you and things like that. But, it can take a day. You can be in surgery all day, things like that. I'm more of the, like, when you'll have a therapist and you say, like, why don't you call me on this or something? And you're like, well, I was afraid to talk and I didn't want to.
Should be the last thing.
But that can be my fault too, if
you didn't create an avenue of trust.
Yeah, and to say, listen, you need to know that, like, call me anytime. Yeah. It's like, well, I called Joe Schmo or Jane Schmo, and he or she yelled at me and really made me feel bad that I was bothering them or something like that. That's a mortal sin, that you really, like you said, you're just cutting off, you're chopping the railroad tracks right in half, and we'll never get them. Nothing's ever going to get through. And so, there has to be some, people have to know, like, listen, if we're part of a provider team, the therapist and surgeon, like they're basically the lines are open all the time.
Yeah.
As long as we're taking care of the same people.
Yeah. So let's get, as far as getting back to the shoulder.
Yeah.
If someone has a supraspinatus tear, what's the typical symptoms that you'd see upon like when you're examining their shoulder?
So usually people will have pain with overhead type motion. They'll complain of pain.
Anything forward, anything to the side?
Yeah, reaching out to the side, reaching up into the cupboard, grabbing things.
Yeah, what does that rotator
like
cuff muscle do? What motion?
So the supraspinatus typically is more for elevation. It's is what we call abduction, where it's muscle out to the side. Now that's assisted by the deltoid and certain ranges of motion, but that's the one that is more for kind of forward elevation and reaching up overhead.
Okay.
And so night pain is one of the hallmarks of rotator cuff pathology that they'll say. And I think what happens is it's kind of a subclinical pain, and then you go to bed at night and the demons come and all the distractions that kind of kept you away from feeling that pain during the day and tend to come at night. And so people say, it's waking me up 2-3 times a night. And it's pain kind of in the lateral deltoid region. So
it's kind of right on the outside.
When I say lateral, just on the outside portion of that shoulder.
Yeah.
And so, and they'll complain of just kind of an overall soreness and particularly pain with overhead type motions.
Yeah, so say someone comes into your office with that type of pain. You examine them, you determine that potential supraspinatus tear. You don't know upon any kind of imaging. What's your mode of treatment?
So typically we'll look at them, and depending, one of the main factors is how weak they are. So there's certain tests that we can do to assess their strength. And so if they come in and they've had this and we kind of press down and they're really, really weak, you say, this is a high probability there's a tear here. And so
you test their other side to compare, and they're really strong there, but really
they're
weak
strong
here.
And they're just like, wow, that's very painful, or that's just weak and I just can't hold that. Then, then you kind of talk to them and you kind of say, listen, there is a concern here for a tear. What's going on? What's going on in your life right now? I mean, could you have surgery? Would you need surgery? At that point, I mean, obviously we always get x-rays to determine that. And a lot of, if we're assuming the x-rays are normal, then sometimes we would pursue.
Why x-ray before, before PT or before MRI?
Well, x-rays are always kind of the standard for everything, because you're looking to say you could have a tumor in there. You could have, there could be something.
It's a very cheap image that you can miss some very important things. And if you get an MRI first, you could miss a tumor in their bone or a fracture.
It is a frustrating thing. And maybe it's not old school, but you see people and you're like, you've had an MRI and the MRI was normal and no one ever got an x-ray. Like, there has to be a stepwise fashion, and like you said, an MRI is an advanced imaging test. And so, you always get an x-ray to really rule. You're not going to see a rotator cuff tear. MRI or x-rays will only look at bony pathology, but you need to make sure there's nothing weird bony going on. And it's the cheap, easiest, and it gives us the broadest overview. And it's really the basis of the pyramid of care to look at. And so, assuming the x-rays are normal, I mean, if they're not weak, then sometimes we'll say, then it's time, this is oftentimes due to a muscle imbalance. Things are, and you say, and sometimes people say, well, I've been doing a lot of lifting, and, they're doing their beach muscles.
So essentially the ball isn't staying centered on the socket and can be pushing on a certain rotator cuff muscle and kind of breaking it down over time.
Yeah, and it's in the ball, and maybe the muscles that elevate the shoulder. The essential is that the ball has to stay in the socket, or the ball has to be centered on the tee. And if it's not, there's so many things that can lead to just a minor amount of eccentricity there, and then everything starts to break down. And so you would say, gosh, you know what? And then we might start with an injection of, like, say, cortisone in that area that's very inflamed. Only the cortisone is not a long-term treatment at all. That is, what I'll do is say, this is to put out this fire that is happening.
Calm it down.
Till you get to Brad. The long-term treatment here is not cortisone or anti-inflammatories or anything else. This is just to calm it down so that you're going to Brad to get therapy. Okay. Yeah. And if your shoulder's really pissed off, off and it's irritated and inflamed. And then you get to Brad and he's trying to do strengthening and it's hard for him he can't calm it down.
Yeah. We use, the cupping and soft tissue work and A-stem and dry needling to calm it down. But sometimes it takes us 3 to 4 weeks just to calm it down.
Exactly.
To get to the strength.
Exactly. And you can't start, it's just like you're just punching your arm all the time and you're going, so we got to rest it. And so sometimes, exactly. Your modalities along with an injection or something like that will at least calm it down that you can begin then to restore the balance. And that's where your professionalism comes in.
Yeah. And ultimately in therapy, the biggest thing that we do is exactly what you're saying is we figure out, I explain to people your shoulder's like a tire going down a road and every once in a while it gets imbalanced and you might train really hard. You might be doing a lot of push-ups, a lot of pull-ups and not a lot of pulling, right? There's not a lot of rotating.
Exactly.
And your rotator cuff can get extremely weak and that's what stabilizes your ball on your socket. And you might have a great tire. It's a great shoulder, if you follow my analogy there. But every once in a while, you gotta reweight that, right? And that's what we do when we get our tires rotated and tires rebalanced. The little weights that go on it, balance it out, and it's still a great tire. And now it's balanced, right? And the majority of the time, I was looking at research last night in a randomized control trial. 85% of rotator cuff tears get completely better with therapy, and a lot of it's just a muscle imbalance that we develop over time.
It is. And that's where, and especially in younger people, and that's the first thing I'll even ask them. Have you started lifting or anything? You've been doing lifting weights? And, so they've started a gym program and, and everybody goes in and does their beach muscles. They're going to do their delts, their pecs, their lats. They're doing all those things. And, and just like you said, I said,
a lot of pushing, not a lot of pulling.
Exactly. And I'm like, you're going to do these exercises and you're going to do muscle balancing exercises and no one's going to be at the gym being like, hey, Brad, you're ripped, man. You're doing 10-pound cables.
Yeah, exactly.
I can't believe how ripped you are. But I'm like, that's as important as as your military presses.
I mean, I go to a CrossFit gym, and a lot of people. There's the main portion of the workout, and then there's always an accessory piece at the end.
Yeah,
it's like 10% of the people doing the accessory work. And the accessory work is the stuff that you're talking about.
Exactly.
It's the rotational stability. It's the muscle balance. Because most people develop shoulder pain over time.
Exactly.
It's years of imbalance. And then finally it catches up to you. Right. And then it takes time to get back out of that. Right.
Exactly.
But a lot of things that we focus on in therapy, you have all these different modalities, but it's a progression of passive range of motion and then active assist range of motion and then active range of motion and then light isometrics, which is like you're just gently pushing up to percentage before pain, and then concentric and eccentric, which is rotational or going contracting the muscle or unloading the muscle, right? And then bracing or taping, but figuring out how do you decrease the pain and then improve the function. And a lot of people are like, well, I'll just YouTube it. I'm like, well,
and that's where
there's 15 steps in there and you just skipped 4,
Yeah. And the other thing too, which is, why I place so much trust in you is like, there's the art and science of therapy in medicine, and one of the problems that we have even as surgeons, there's certain protocols that we use that are general guidelines and they're kind of science-based for how strong is this tendon at 6 weeks, how strong is this tendon at 12 weeks, things like that. But, there's a lot of people sometimes who just look at these things and follow them I'm
going to follow this protocol, phase 1, phase 2, phase 3. This is the Brigham
and Women's protocol and we're going to do this, and at this point, and you have to...
And a lot of the protocols are outdated, or some of them are even created by a surgeon, just their preference, no research to back it up.
Exactly. But also to just say, hey, listen, when you say this is a rough guideline for where we want, and it's not written in stone. And that's where, where I enjoy so much working with you, because you say we can go, we don't push things too much to advance them, but sometimes it's like, hey, we're going a little slow. We need to back off a little bit where, I think that maybe we're pushing too hard and they're getting a little inflamed. Like, there has to be some clinical decisions that are made.
Absolutely. There was who did we had? We had our other patient, our boxer gal.
Oh yeah,
she was super fun to work with, and she had some. This wasn't rotator cuff; it was more instability. And we had to collaborate a lot on that one because she was a fighter. She was a competitive fighter.
Yeah.
And instability mixed with boxing is not ideal.
Not a good combo. I know.
So we both had to be in agreement, like, all right, when are we saying we're ready to hit the bag?
Yeah.
You know, because there's so many forces going through the shoulder when you hit a 150-pound bag or someone's face, you know, like,
and your fist stops dead as you're throwing your entire body weight into it, and what that does for the shoulder. But,
so we had to be like, I remember we jumped on a call and we're like, we're ready. We're ready to open it up, but let's do 50% first, make sure that goes well for a week, and then we'll gradually add load.
And call me if she's getting inflamed. We can do this if she's, if things are getting pissed off in there a little bit.
Yeah, and she's doing awesome now. She did graduate.
I know. I know. And she was, again, those are the things. I mean, she's such a pleasure and such an honor to take care of her, and and to see what people are doing.
I love it. I love what you do, Paul. You're so good at just connecting with patients and making them feel heard and validated, not getting stuck in the repetition of what you do. What are some practices that you do to help you stay connected and remember you're treating humans?
That's a good question, really.
You're so good at it, and you've been doing it for 25 plus years.
I enjoy it more now than I ever have, really. And I think that's a really good question. I was thinking about this the other night because, and you deal with it, and even the consumers of healthcare deal with it. It's a frustrating, the business and the BS and the insurance and all that stuff is incredibly frustrating. It's frustrating for therapists and more so for patients, and we have to realize that, and for physicians. And people really kind of you can get burned out on that, and it's the leading cause of why people leave medicine, and the paperwork and the bureaucracy and the regulation, and that stuff can take you down. And it's like, but I just, whenever something happens, you get some BS phone call from some regulator or something like that.
For sure.
It's like, God,
telling us how to do our job.
Yeah, exactly. Yeah. And
the surgery's not appropriate. You're like, let me tell you if this surgery is appropriate.
Exactly.
Been doing this for 25 years.
But like, sometimes you use that as a positive influence. Like, okay, the only way you're going to get around this, the only way you're going to get around this frustration is go back in that room and love up your patient, because your patient's like, they're just awesome. We all have there's difficult people in every profession, but for the most part, and you realize like just how truly lucky and blessed you are to do this, to do this for a job every day.
So it's really a practice that you do to say, I love the and just to remember why you did it in the first place.
I mean, I think like inherently I love just hanging out with people, and I mean, and I love just talking to people, and so it kind of suits me in a sense, but it's just, there is a lot of, like, you remind yourself, like, man, this is the best effing job in the world.
Absolutely.
It is. And and I think you feel the same way about your work, and you go, this is what I was meant to do. And so, and when you get in that groove, and just and when you just see, and it's something that's so beautiful about orthopedics, though, because in your practice too, you take care of such a broad spectrum. You're taking care of teenagers, you're taking care of, today I did shoulder replacements on 80-year-olds, and so and everyone's at just such a cool phase of life that you can enjoy each phase of life that they're at.
For sure.
It's just a pleasure.
I love working with you, Paul. You do great work, and you're making so much impact on the world. So thank you for what you do.
No, Brad, back at you, buddy, because you were one of the best, truly one of the best I've ever worked with. And I mean, like I said, pleasure's all mine. It's an honor and a privilege, buddy.
Well, thanks for being on this podcast. I hope we really, let's do it. Let's do this often. This is good. I hope people have understood more of what rotator cuff's about, and repairs, and what to expect. We'll have to dive deep more into labral and instability and ligamentous things, but the shoulder is one of the most complex joints, and we'll dive more in another time. But thanks for joining us today.
Always great to be with you, Brad. It really is.
Appreciate it.